Okay. Today's topic for the Navigator Focus series is navigating bias, considerations for behavioral health and substance use disorder. Sorry, give me one moment. Having trouble. There we go. Um, all of what you see today is part of the Creative Commons with support under the California Department of Healthcare Services, so DHCS. CA Bridge is a program under the Public Health Institute's Bridge Center. And as a reminder, our goal is 24/7 access to substance use navigation and addiction treatment in every California hospital. Um, and we're currently working on topping that goal and moving and expanding to even more, which is super exciting work. Um, we're doing a lot of this work through, trying to shift the system of care and the way that care is provided to kind of shake up and revolutionize that system through the CA Bridge model. You should be familiar with the model, which is three pillars: low barrier treatment. So that would be the medication side of things. So buprenorphine and methadone, naltrexone, things like that. The connection to care and community, which are a lot of our attendees here. So navigators, CHWs, peer support specialists, SUD counselors, the whole gambit. And creating a culture of harm reduction so that advocacy piece of like internal stigma reduction and harm reduction, as well as external work for that. And for our announcements today, we have a Navigator peer support group. So we invite you to join peers who can support each other in a number of different ways. So the next one is Wednesday, January 28th at 3 p.m. And just to plug here, Chaia usually leads this peer support group and is looking for volunteers to co-host or co-lead future groups. We have our Navigator office hours. So we're relaunching Navigator office hours, which is a great opportunity for any and everybody in the community to attend and ask questions and get real-time answers as well as peer-to-peer knowledge exchange regarding uh, you know any of the work that we do for navigation. So that is Wednesday, February 4th at 11. We also have our Navigator update, which takes place the second Wednesday of every month. This is specifically for those who perform navigation. You are all welcome to join. This upcoming topic is on professional growth tips. And we have our regional collaboratives. So the next one is a virtual regional collaborative. This is statewide. So everyone is invited throughout the state. It is taking place Tuesday, February 4th or 24th at 9 a.m. You should have, if you're subscribe to our newsletters and emails. You should have received something. If not, please reach out and let us know. And you can always access this information on our website under live training. We have an in-person one coming up in March in San Diego. So any counties surrounding San Diego are invited. If you want to make the journey from farther away, please feel free to do so as well. But the content will be likely specific to that region. Um, but share that information, invite everyone else. It isn't just SUD service providers that are invited. It could be any and all community resources and people that you think should be in the room. So for those of you who are CEU earners, these are the objectives for today. I hope that you enjoy the content because we have a phenomenal speaker. And so to introduce Dr. Nola Veazie, who is the CEO of V Solutions Consulting. She specializes in substance use disorder, offering training and CEU as well as consulting services to organizations that assist individuals in recovery from SUD and mental illness. This is our third year inviting Dr. Nola Veazie to facilitate a training on bias, and I promise you that this time around, and neither do any of the others, but you will not be disappointed. This is like different information and really exciting, great information that's very relevant to the work that all of you do. So I'm very excited to introduce Dr. Nola Veazie.
Thank you so much, Latoya. I hope I can live up to that presentation. I'm going to go ahead and put up my slide and welcome everybody. Good morning. If you are here in California or on the West Coast, good afternoon. If you're somewhere else, buenos dias. If you are here in California, buenas tardes. If you're somewhere else, bonjour. For those who speak French, après-midi, if you are in the afternoon somewhere else. So I wanted to cover all aspects, English, French, Spanish. So whatever you speak, I don't speak any other languages. So I welcome you. Today, we're going to be talking about navigating bias, ethical considerations for people in the behavioral health field and substance use disorder. But I kind of want to premise this first. I want to talk and take us down on a journey about how our brain functions. Understanding bias requires an understanding of, what happens in the brain, because we've all experienced bias and we all have biases ourselves. So the brain creates mental patterns and associations about the world, and we call those social cognitions. And what social cognitions do is they're used to perceive, to interpret, to remember, and to make judgments about people and about social context or social situations. So, in other words, is our brain are creating all these little patterns and associations so that we are able to make sense of our social context, social situations, and about people. But it does more. What it does is it shapes how we understand the behavior of others, how people behave. So it shapes how we understand their behaviors, but also shapes how we perceive their intentions. So we perceive that people are good or bad, or that they're going to harm us or not, based on all these social cognitions. And it also influences then how we behave in response and how we respond to people's behaviors. I'm going to go ahead and go on with the slide. Today, we're looking at two populations in particular: how bias affects people who are justice involved, and how bias affects people who are immigrants looking for language access. I hope that this presentation brings you information that you can use. I hope that is useful. But let's start out by understanding bias. What is bias? Well, when we think about bias, bias is just that disproportionate inclination that we have in favor or against things. We all have bias. Some of us like vegetables, and some of us just don't like vegetables because of whatever, however we grew up, or whatever interaction we had with vegetables. So we have this disproportionate inclination to favor some things, favor some people, favor some topics, and be against others. It usually, though, comes as a closed minded prejudicial or unfair position that we take. And these are thought processes. So that's bias, but we're going to talk about something that is a little more um, outside of our awareness, and that is implicit bias. Because we might be aware of our bias. Most of us are aware of those bias that are explicit, but not the bias that are implicit. And those are more complex. Why? Because they're outside of our consciousness. I don't even think about some of the things that I don't like or how I've created those mental associations about certain people or certain things. They're also based on attitudes, the attitudes we have in response to those people, the situations, the atmosphere. We have attitudes toward them, and those are based on those mental patterns that we've created, that our brains have created. Another thing is that they're based on those associations, those mental associations. If you're old as me, you remember back in the day when they had you saw those TV shows about, the bad guys and the good guys. The good guys wore white hats so we could associate it. We could determine who was the good guy because that person was wearing a white hat versus the bad guy because they were wearing a black hat. And we make those mental associations and then take them into our relationship with our environment and with other people. So when we see people who look a certain way or they're wearing a certain clothing type, then they must be associated or lumped or in this bucket with the bad people or the good people. So most of us, though, believe that bias and discrimination are the same thing. And I wanted to clarify this before we go on because it's important that we not only understand what bias is, but how it's different from discrimination. Many people won't talk about their bias because they see that as, oh, I'm not prejudiced, but we all are prejudiced because we all prejudge. And prejudice itself does not mean that we keep other people from, accessing healthcare, for example, or accessing the care that they need. So let's look at that. Bias, which says that unfair prejudgment or prejudice in favor or against a thing or a person or a group, and we compare one group to the other. Discrimination, though, on the other hand, is an unjust or prejudicial treatment. And when we talk about that, this is where prejudice or discrimination or prejudice as it relates to discrimination is bad because it keeps people, it categorizes people, first of all, and it keeps them from accessing something. So when we think about discrimination, we're thinking about that prejudgment in treatment because of people who are different because of their category, especially on the grounds of ethnicity, age, sex, or disability. And so that is the difference. So it's not bad necessarily that we have biases. And what we want is to be aware of those biases and how they can impact our clients and how they can impact individuals around us. So let me get to the next slide. So, what are some of the consequences of bias in healthcare? In order to do that, in order to even look at that, we have to look at statistics. Not everybody likes statistics, but statistics play a role in our interactions with people who are different from us. Now, statistics about discrimination and bias, they play a powerful and double-edged role in how health care providers can interact or do interact with individuals who are different from them. On the one hand, when they're used well, when we're using statistics well, they can promote equity, they can promote accountability. But when they're misunderstood or misused, they can reinforce stereotypes and distance. Let's look at some of the statistics that I found and just kind of just for informational purposes before we get into the actual meat and potatoes here. 10% of medical professionals are less likely to admit Black patients as a result of bias. So if a person of color might show up to the ER, And these biases are based on studies that are years ago, decades ago, that are still, the studies may not be used, but people still hold these mental associations. And so 10% of medical professionals would say, well, Black people have a higher tolerance for pain and may not need to be admitted. It's not because they don't like Black people, it's because of some of these mental associations. 20% of Black adults and 35% of adults of Latinx heritage had problems accessing insurance. Again, because of some of the prejudgments or the implicit biases that healthcare departments or the healthcare system may have. People with a history of addiction are more often perceived negatively by healthcare providers. We're going to get into the weed. We're going to look at that. We're looking at two specific population, and hopefully I can bring some clarity. And this is where I got these studies from. So let's look at bias in the justice system and what does that look like. First of all, let's start with some more statistics. Arrests. Non-citizens of color are more likely to be arrested. The statistics say that Black youths, for example, they account for 17% of the U.S. juvenile population, but they make up over 50% of arrests. Bail. The racial gap in granting of release without bail between Black and white defendants increased about 2 to 10%. So we could look at these statistics and say, okay, we need to do something different as it relates to healthcare or mental health or substance use disorder. And like I said before, statistics can also be used to stereotype and cause distance by reinforcing some of those mental associations. So we look at justice involved clients. So looking at justice involved clients through the lens of bias as they're trying to access healthcare, whether it's behavioral health or substance use disorder clinics, there's an assumption that the scales of justice is without bias. What does that mean? It means that if they're in prison, they must have done something horrible or they must be guilty. And we found that some people that are incarcerated and the Justice Department found them guilty may or may not be guilty. And that is among people of all ethnicities and all races. The other thing that we look at when we look at justice involved clients and justice involved individuals through the lens of bias is not recognizing our own implicit bias. Just a little bit, about me and some of the biases that I have. One in particular, I spent over 20 years in the U.S. Air Force. And back in those days when I was in the Air Force, I'm a retired Air Force, people could not have visible tattoos. So if you had a tattoo and that was visible in short sleeve uniform, you couldn't come into the Air Force back in the 80s, 70s, 60s. You couldn't enter the Air Force. Now, the Navy would take a person with tattoo, and it created some implicit biases that I was not fully aware of because it was implicit. I thought if they couldn't come into the Air Force because they had tattoo, perhaps there was some type of justice involvement for that individual or something about that individual wasn't professional. Those are biases that I held and wasn't aware of. But when I became aware of it, and that's why it's so important that we are aware of our own biases. So what I would ask you to do at this point, if you have clients who are justice involved, think about some of the biases that you may hold that kind of impede your relationship with that person or providing the best care for that person. Another bias is this individual is not redeemable. They did something wrong, they're bad, they're criminal. And so rather than using person first language, we call the person a criminal. And so that is a bias based on, again, those mental processes, that social cognition that we may have. Not using person first language. Well, statistics say, I just showed you some statistics, and the statistics could be viewed as, well, people of color might be committing more crime, or people who are of Latin descent, or certain people are committing more crime because A, B, or C. The other thing is that we're not aware of our divergence bias. And that means that I will favor my point of view and can contribute, and that contributes to polarization. Even though I might bring you some information that dispels some of the views you have, if we have what we call divergence bias, we might tend to just stick to what I believe, well, statistics says, and not looking more into the statistics just at face value. So some of the unconscious filters that presents itself because of our unconscious bias as it relates to people in the justice system are as follows. Criminality equals danger. So if we see somebody who is justice involved, well, they're a criminal versus a person who's committed a crime. That's different. So we look at people differently when we use first language. So we automatically assume if someone with a criminal history is also violent, is unpredictable, or a safety risk. Although that might be true, not everybody is. But those are biases that color how we see clients if they're justice involved. Regardless of the individual's actual behavior, the offense type, or their current need. So I want you to think about the filters as I bring them up. Do I hold some of these filters? If they committed a criminal act, oh, they're a danger. Another filter is deservedness filter. Now, let me tell you a little bit about the impact of the previous filter. So if we have that criminal equals danger filter, then we tend to over monitor. There's a reduction in trust about the individual. There's unnecessary security measures. Even though the individual may have done time a long time ago, now they're out of prison. Perhaps they were in prison because of substance use disorder, but now they're out of prison. The person might have been clean and sober for the last 20 years, but because we have that unconscious filter or that implicit bias, then we say, no, they're just coming to try to get drugs. They don't really have pain. They're just trying to. So we put in place unnecessary security measures, or we just simply avoid that person. The deservedness filter, that's believing, whether it's consciously or unconsciously, that people who have been incarcerated, they brought it on themselves. And that's a bias that we have. And therefore, they deserve fewer resources, less compassion, or limited medical attention. What is the impact of this when we feel that a person deserves, what they got, and therefore do not deserve some of the resources that are available? We tend to withhold empathy. We tend to minimize their symptoms, or we provide substandard care, whether it's in the healthcare or in behavioral health. The compliance non-compliance filter. What does that mean? It assumes that justice involved individuals will be non-compliant. They will not take medical advice. They will not follow treatment plans. You had a substance use disorder in the past, you relapse, you're not going to follow the treatment plan. You're just trying to get more medication. Or they may not comply with their appointments. Here's the impact of that is then we have lower expectations about the person. We give less detailed instruction. Well, after all, why am I wasting time? This person is just having some drug seeking behavior. And so they're not really interested in getting better. There's fewer treatment options also that are offered for this individual. Socioeconomic filter or status filter. And what does that mean? Linking incarceration with lower income, unstable housing, or unemployment, and allowing those assumptions to shape our clinical decision. Although we see from reading not treatment so much, reading the research and looking at statistics, we see that a lot of people who are incarcerated come from lower income neighborhoods or unstable housing, but we find that people who came from higher income, middle income, or upper level also commit crime. So if we put people or we mentally associate only people from unstable housing, unemployment, lower income with or in other words, we associate socioeconomic status as a filter with individuals who are coming in, then we say, well, uh, the impact is that we don't have too many choices for that individual. They don't have insurance, maybe. Making assumptions about insurance coverage that if they have insurance, maybe they have Medi-Cal or something else, or lowering treatment goals for the individual. So again, looking at the filters and seeing, based on those filters, how do I interact with that individual based on those social cognitions that I might have? The other thing is addiction. We look at addiction as a moral failing. And so when we view substance use or relapse among justice involved individuals, it looks intentional. It looks like misconduct rather than a chronic medical condition. And so, if, as I said earlier, when we looked at social cognition, we also, it shapes what we think about the other person's intention. So if I look at an individual thinking that their intention is just to, get over, just to get something, and their intention is not benign necessarily, the impact is a blaming attitude, reduce patience with that person, more punitive response rather than a supportive intervention. We feel that, hey, this individual is just trying to get over on the system. So again, we want to step back and look at our filters and say, okay, how am I viewing? What are the lens that I'm looking at this individual through? And are they objectives? When I teach cultural competence, one of the things that I tell those who attend my cultural competence classes is that we want to use our brain as a camera. What that means is that a camera only sees what it sees, it's very objective. But our brain adds a layer of filter, and those are those unconscious filters or that implicit bias to what it's seeing. So we're not only seeing somebody who may be of a different color or a different ethnicity or just different than us. What we see is somebody that is potentially more dangerous because they don't fit the schemas or they don't fit those models or those roles or those patterns that my brain has designed to keep me safe. So when our brain does these patterns is just in an effort to keep us safe. It's saying that, okay, that individual is a little different. You need to kind of look at them and watch them because they may be up to something. And those are unconscious filters. Doesn't mean that it's a bad thing, but it means that we need to be aware of them so that we don't use them in a way that keeps people from getting the services that they need and the services that they deserve as human beings. So here's the one size fit all filter. So we apply the same expectations of care approach to all people who are justice involved without considering diversity. People come from different backgrounds, even people who are the same racial, the same racial profile or ethnic profile are different. Come from this. We have to be culturally sensitive and competent that people in the same buckets that we put them are different within themselves. And so we have to consider diversity in background, diversity in culture. We also have to consider trauma history. Now, if we look at some of the statistics regarding people who are incarcerated, and I've done that, and I've done at least one study regarding that, is that we see a high percentage, specifically for women who are incarcerated, at least 90% have some type of trauma, physical or sexual trauma. So we know people have trauma regardless of race, regardless of culture. The other thing that we might put in this one size fits all bucket is that oh, this person probably have a very low health literacy. They don't know much and they're not going to understand what I'm saying. If I'm the doctor, if I'm the nurse, or if I'm the helper, if I'm the community care person, navigator, they may not understand those words. And so we talk down to people, and one size does not fit all. 7, the trauma minimization filter. We assume that their incarceration toughens them up. You know, hey, if you're incarcerated, if you were a gangbanger, then you must be tough. And so this is not going to create any trauma or cause any trauma for you. And what I found, working in the state prisons, presented not just to drug and alcohol or mental health counselors, but also to mentors who are people who have a long-term incarceration. So we cannot assume that the person is so tough that being stripped search, before they come to a class is not going to affect them. That's not true. And so we don't want to minimize, how incarceration affects the individual. So sometimes, when we're working with people who are previously incarcerated, we assume, well, this person is tough, they're not afraid, they're not vulnerable. And so we don't use trauma-informed language or trauma-informed intervention to interact with the person, to treat them, or to assess. Here's the impact of that is that under recognition of mental health needs, PTSD or anxiety can cause more problems, can also re-traumatize the person. Credibility filter. This credibility filter automatically doubting or discounting that justice involves patience, whatever they self-report is not true. We automatically doubt that you're having that level of pain. You're probably trying to seek drugs. And this is because of the stereotypes around deception, manipulation, or just that seeking drug. Again, stepping back from these filters and saying, okay, I know that this might be true in some cases, but how do I interact with this person so that I can rightly assess what the person's needs are? Cultural and social distance filters. That's viewing justice involved people as fundamentally other. It's them versus us, or outside our social norms. The impact of that is that we don't have much empathy. There's a reduction in empathy. There's less rapport. There's less interactions, and there's an increased social disengagement from people who we see that are just trying to, they're trying to play the system, because of those thoughts, those social cognitions that we have about people who are different, or people who are incarcerated or previously incarcerated, as we're talking about in this population. And then there's the linguistic or communication barrier. We assume that someone who uses slang, non-standard English, or limited medical terminology is less intelligent. And we've seen that there's been tests done throughout the decades and century about people who were different, people who were of different racial groups or different ethnic groups, about their intelligence because they didn't speak like the norm, like, the normal, not normal, but the normative population. And so we just assume that, hey, this person is less intelligent, they're less motivated. And so they may seem like this person is resistant to treatment, when in fact the person might be ambivalent because they don't understand the direction, or they don't understand the language, and may be afraid to ask. I don't want to feel stupid, so I'm not going to ask. But what happens is, because of our filters, they do look stupid to us. And so we're less empathic. We don't engage the person with empathy. And we don't do our best to provide what that person needs. The other thing is that we look at that individuals as less capable to manage their health. The impact about that is that we talk down to people. we withhold information, we exclude the person from shared decisions, and or we just talk over a person. We talk, to the navigator, like say the healthcare provider talks to you as the community caregiver, or talks above the person as if the person was not there. So I've talked a little bit, and I'm not going to go through. If I have some more time, I want to share a little bit more, some more filters, but I want to go on to how do we advocate for individuals who are justice involved? And so let's look at that. We want to identify the barriers to access. What are some of the barriers, and what can you do to help that person, access care? Those unconscious assumptions about the individual, how do we how do we tear those down? How do we tear those barriers down? About whether they deserve equitable care or not, those stereotypes. We want to combat the bias and the stigma. So just like we people with bias who are not aware of their bias may think that this person doesn't deserve full access or service. For example, when a provider or an institute fail to prioritize an interpreter or to translate a material in the sense of someone who needs language access. But in this case, when a person does not understand medical language or terminology, breaking that down so that the individual can understand. And this is where you can advocate for that person. We want to strengthen care coordination, ensure that we are the bridge between the client, the person who is justice involved, and the healthcare provider or the behavioral health provider. Helping them to locate some of the care, the resources that they need. Empowering the individual. One of the things that I always talk about is autonomy. I teach motivational interviewing, and one of the I guess before motivation, before we are fully motivated, is having a sense of autonomy, and that is having the sense that I'm able to self-direct, having the sense that I'm able to get the resources that I need, whether it's in healthcare or in any other care. And how do you empower the individual? By helping them build self-efficacy so that they can navigate for themselves, and not just depend on you, but teaching. How do I navigate the system to get the resources that I need, to get the help that I need, to get the education that I need? So empowering the individual by helping them build a sense of autonomy, that I belong here, that sense that I have the tools that I need that are necessary to navigate the system. And you, as that bridge, can help empower the individual in that sense. Using a trauma-informed approach. We don't know, we know that it's a high percentage of individuals, especially who are justice involved, have experienced trauma. We don't need to know what trauma necessarily, but we need to understand that there is a possibility that individuals suffered some form of trauma. Understand what, as we get to speak and understand and know more about the individual, what are some of the triggers that I notice when I'm helping that person navigate this space, whether it's healthcare or another space? What are some of the triggers that I notice? How does that person behave when interacting with someone who is not empathic, who is not listening? How do they behave? And so helping them to navigate them using person first language rather than the addict, the person who is suffering from substance use disorder, using an approach that tells the person that, hey, I'm here. I may not understand everything, but I do know this is that we're human beings, and that all of us generally have experienced some form of trauma. And what I think is traumatic may not be what you think is traumatic, but I need to be able to navigate with you as a human being in that space at that time. And I know in this field, we call it meeting people where they're at. But I always ask, what does that mean? And so I would ask you to inquire, what does that mean to me? I hear it, I say it, but what does it mean to me? Advocate at the organizational and policy levels if you have that chance. Advocating for change because you are right in the mix. You're able to see what is lacking, and therefore you're able to also say, hey, we might need to change this up a little bit. Upholding the ethical standards. I'm looking at my thing, and so I want to move on. So let's look at it. Implicit bias in the immigrant population. What is that? What does it look like? Um, what does that mean? So language access and implicit bias. And I see you, Latoya, so I'm going to move up or to speed up. So lack of language access is rooted in implicit bias because it arises from the following: unconscious assumptions about the individual. If they don't speak the language, they might not be too smart, or if they don't speak the language, they might be. All these implicit bias and assumptions, stereotypes that we have about the individual. Systemic norms. And when we talk about systemic, is it cultural norms? If your culture is different from the individual, there are certain norms that we live by and we try to apply it. When they don't fit in those norms, the bias comes up. Minimization of harm. We want to ensure that we are not harming the individual more because we're not providing access to language if that's something that is needed. Uh, Language access also causes implicit bias because of historical inequities, things that we might be aware of, things we're not aware of, but we need to know that there's a history behind that culture. And so there's some inequities, even if we don't know it all. Just knowing that is important. So why is lack of language access rooted in implicit bias, like we say? Assumption about who deserves full access. Well, if your immigration status is not okay, then you don't deserve full access. You don't deserve to see a doctor. You don't deserve to get mental health care while you're here. Stereotypes that non-English speakers are less capable and less engaged. Normalizing English as the only valid and or efficient language rather than getting someone who is certified, someone who can speak the language good. What tends to happen is that we might grab one of our peers who kind of speak Spanish or French or some other language and engage the person in a way that does not give them the full picture. Just because you speak a language doesn't mean that you're proficient in the healthcare nomenclature or legal document nomenclature. It doesn't mean that we have a proficiency or that we even know how you say that in another language. So most often what happens is that the person who goes to the doctor, a person who, let's say, speaks Spanish and only Spanish, they're monolingual, may have their child translating. Well, the child may not be familiar with these medical terms. So getting a certified translator or a person who's a translator who does this for a living is language access. Underestimating the consequences, for non-English speakers. If we're not translating things correctly, that person may go home with an idea that, oh, they said this based on their child's explanation or translation and may not get the necessary information. Lack of representation in leadership, historical patterns of exclusion, and blame the patient mentality. So again, family members have their unconscious filters. Family members' unconscious filters are, hey, I'm tired. I'm just going to translate as much as I can. And they believe in that family members speak enough of the language to accurately translate. The exhausted doctor who skips question because she does not know what that means. The impatient child who rushes through options rather than translating something that is vital for that person. when you don't provide language access. The spouse who thinks they know it best, so they're not going to translate everything the doctor says or that you say as a care provider, a community caregiver. No, you don't need that. And if you don't have a translator there to accurately translate, then that person may not have all the information. A child who protects the parent by omitting information that is vital. And then using coworkers or friends with basic knowledge of that language to translate is not uh, language access. How can you kind of advocate? Number one, promote culturally and linguistically appropriate services, strengthen care coordination, become aware of your own assumptions, especially those implicit bias. Use a trauma-informed approach. Make invisible harm visible. Such an invisible harm might be how we relate to people. And they know something is different, something is wrong, but it's not explicit. Talk about that. Have people talk and understand where they're coming from. Help providers recognize, pause, and reflect and understand how this affects their interaction, especially bias interaction affect their interaction with their clients or their patients, and of course uphold their ethical standards. Here's some actions that you can take. Be aware of your own bias. Let's start there, especially those that are implicit. Has it become a barrier to what I do? Has my implicit barriers or my social cognitions become a barrier with my client? I might be saying something and look in a different way. So verbally, I'm saying one thing, but non-verbally, I'm saying a total different things. And there's a disconnect between what I'm saying and how I'm reacting. People know that. People are aware. Know how to access linguistically appropriate services in your area. Encourage the use of trauma-informed language. As I said earlier, person first rather than disease first. Model respectful interactions with people. Know your limitations. When there's a need to translate technical information, get a technical translator, get a translator who is adept to translating in that particular language. And so I want to stop here and be able to answer some questions. I'm going to stop my PowerPoint so that I can have time, because I see I have less than 10 minutes, to answer any questions or anything. Latoya, let me know if people have questions in the chat, or if anybody has any question, I will be glad if I can answer it. I will do that.
Well, there's definitely a lot of love for you in the chat, and the content that you're
Wow.
presenting today is so relevant and rich. We do have a hand raised from
Janelle.
Janelle. Um, let's see if we can. I'm not quite sure how to. There we go. Are you able to unmute, Janelle?
I'm sorry, that was a mistake. I just thought this was a recorded webinar, but nice to meet you. I enjoyed the webinar. Thank you.
Nice to meet you, Janelle.
All right.
Thank
Thank you.
you.
All right. Any other questions? Let's make a great use of the brilliance that is Dr. Nola Veazie and ask some questions that come up for you surrounding this presentation. Michelle.
Hi, first of all, I want to thank your organization for making this extraordinary presentation possible. I especially want to uplift you, Dr. Nola, for your
Thank you.
brilliant presentation. I have never heard um, this topic presented in this informative and relevant way. My question to you is, um, there are so many trainings on this topic. There are so many continuous opportunities for growth and development. And I'm just curious to find out um, how does one, or what recommendations would you offer for the application of the information? because it's one thing to get all this brilliant information, and it's another thing to really apply.
I think the application, that's why I like trainings versus, I love that they invite me to the webinars because in the trainings, we really deal with the application. You're so right, Michelle. It's one thing to get a bunch of information. People sometimes want the PowerPoint and they get it and it's just information. What we do in our training is show people how to apply it. And I know that there are other trainings out there where it focuses on application. My thinking is always theory to practice. What can I do? Which is why I presented some points, some main points, and the things that you can do as a navigator or as a community caregiver or as a caregiver, in how to interact with clients. Like, how can I be trauma informed? What do I do to be trauma informed? Is ensuring that I build, number one, self-efficacy for that individual and build and uplift their sense of autonomy. Because what we found and what the research shows is that when people don't have a sense of autonomy, even if they're motivated to do something, they may have abilities, but they don't have the capabilities to take that ability and put it into practice. So, what I suggest to answer your question is a training that focuses on taking that research, taking that information, and putting it into practice.
I love that. That was actually a really great question. And thank you, Dr. Nola, for your insights on that. And I did also I want to call out the action steps that you shared towards the end there before the questions. Some of those action steps do seem like applicable things that we could all do to put into practice everything that we've learned today.
Absolutely. First thing is be aware of our own biases. It is freeing when you're aware and knowing that bias and discrimination are two different things. And so you don't have to be ashamed that you have these bias. Our brain just helps us to interact with our environment by creating these patterns, by creating these social cognitions. Now, how we engage those to engage our environment or to engage people is up to us. So somebody asked if I would make the distinction between cultural competence and cultural humility. Number one, cultural humility is knowing that I am not the expert on somebody else's culture. I'm barely the expert on my own. And so staying humble to learn from the person you are working with, the person who you are helping, is cultural humility. Sensitivity is just being sensitive that there are different cultures, there's differences in cultures, but competence requires steps that we take to learn not everything about the culture, but learn the things that are important to that individual and how we provide treatment.
Very, very well put. Thank you. One of the things that I learned about cultural competence was that it's a lifelong thing. I think as well as cultural humility, but with cultural competence, one could never fully be competent in someone else's culture, because they're also vastly different. So it's a constant thing to like learn and understand, and take those steps, as you said, to be competent or to try to be more competent in the culture of others.
Absolutely. One of the things that I learn is that, when I teach cultural competence, I break it down to the organizational level and what they can do regarding policies and procedures, that includes, culture, the competence in the culture of the people they serve. But at our level also is not thinking that we know best for the individual, but to have that cultural humility and finding out from the person, what are some of the important aspects of your culture to you? And how does that relate to, let's say, substance use disorder, if that's what we're working with?
Yeah, I love that. Thank you so much, Dr. Nola. I really appreciate your your time today and your ability to join us and talk through this really, really impactful and very useful information today. Thank you for the questions as well, for the audience and all of the love that's shared in the chat. Before we run out of time in our final 2 minutes, I wanted to just kind of go over these last couple of slides. So here is the knowledge check that's available for each of you to test what you learned today. We have all of our resources available for you on our website. We have a plethora of resources in our resource library for you. Use this QR code to access, or if you have our webpage saved on your browser, go to your favorites and click that link and peruse our resources. As always, all of our webinars are available for you to earn CEUs on our CA Bridge Academy, and we have CMEs available for our doctors, physicians, NPs, PAs, and for nurses. And a wide range of like other designations, SUD counselors, peer support specialists, CHWs, like you name it. There's something for you on our CA Bridge Academy to earn some continuing education units as well. And if you'd like to contact us, if you have other questions, feel free to utilize mentors at cabridge.org to reach us. And we thank you. We thank you very much for your time today. Thank you again, Dr. Nola. Such really, really rich information, and we always appreciate you joining us to facilitate this training on bias.
I appreciate you guys. I'm starting to feel like a family reunion. This is our third year.
Yes, 3 years success. Thank you very much. And so with that, I bid everybody a great rest of your day. Bye.
Thank you, everyone. Bye-bye.